It's been about 17 months since the official end of the COVID-19 pandemic, but its effect on caregivers, stress, burnout, anxiety, remains. In Chicago, Northwestern Medicine has created a continuum of innovative mental health support programs that not only encourage its staff to seek out needed help, but also make a point of addressing the stigma that still holds too many caregivers back from taking care of themselves. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hetterly with AHA Communications. Creating mental health support resources is one thing. Getting people to take advantage of them can be an uphill climb. In today's podcast, hosted by Rebecca Chicky, Senior Director of Behavioral Health Services with AHA, and Emma Jelen, a former Associate Director with the American Psychiatric Association Foundation, we hear from Northwestern's Chief Wellness Officer about how his organization raised awareness of access to its mental and behavioral health support services, and what other health systems can learn from Northwestern's example. And now to Rebecca.
Thank you, Tom. Indeed, it's a great honor to be here with Emma Jelen from the American Psychiatric Association Foundation and Dr. Gaurav Agarwal from Northwestern Medicine. Emma, I think you have the first question.
Yeah, thanks so much, Rebecca, and thank you so much for having me here today. Dr. Agarwal, I wonder if you could just talk a little bit about why and how Northwestern Medicine decided to build such a multifaceted offering of well-being programs and policies that really promote access to mental health care for your healthcare workforce.
I'd love to, Emma. Thank you, and thank you, Rebecca, for having me as well. I think for those who don't know, I'm a psychiatrist, and I serve as our chief wellness executive at Northwestern Medicine. And as I took on these wellness roles, I initially sort of ran from focusing on the mental health aspects related to wellness. To be honest with you, I really wanted people to understand that we were here to address some of the systemic issues that impact our well-being. And this was before the pandemic. And then as we sort of went through the pandemic, it was pretty clear that some of the systemic issues were going to have to be put on the back burner a little bit. There was too much change going on to be able to truly do other system redesign in the midst of a pandemic. And B, it was clear that we were seeing all the data that showed the mental health impacts of the pandemic on our healthcare workforce. And we have tried to organize our well-being program to make sure that folks had resources at the sort of prevention level, hopefully before they have issues. But we realized we had to bulk up our resources available to individuals experiencing distress due to the pandemic, things like burnout, trauma, et cetera. And then we also needed to enhance our resources for folks whose distress had actually progressed on to actual mental health conditions such as depression, anxiety, post-traumatic stress disorder, et cetera. That was really the genesis of, hey, how do we take a comprehensive look at making sure that our workforce has resources available at every one of those levels?
I think the last time you and I met and talked, you had 6 or 7 programs that were part of this multifaceted approach. Could you take a few minutes and maybe share with the listeners descriptions of 1 or 2 or 3 of the programs to give them a sense of the diversity and the different types of audiences that you're trying to meet their needs?
Sure, happy to do so. And the reason we did that is what we have found is it's hard, even when we do things, it's hard for our workforce to tell us, oh, you guys did that? I didn't know about that. And for us, that is disappointing, of course, is because if we build them, but they don't know about it, no one's going to be utilizing them. And so we have tried to figure out what will increase the likelihood of our workforce knowing about things so that they can use them. And for us, one of those things that helps us hopefully have greater penetration of awareness is having campaigns, right? If we do one thing, sometimes that can get lost in shuffle. And to your point, Rebecca, that one thing may be more applicable to one job family or another. When we do campaigns, we're able to have broader communications because maybe not everything will hit you, but at least some things will. and something will resonate or something will say, hey, this is something that I need. And so we said, if we're going to do this, let's try to do a couple of these things at the same time, so we could truly launch a campaign and raise awareness about how the organization takes mental health seriously, and we support you seriously. So for us, again, using that rubric of wanting to bolster resources in the distress zone, we initially spent time creating a peer support program. And that peer support program was initially for attending physicians. And over time, that peer support program has increased to be available to our APPs, our nurses, our pharmacists, and our residents and trainees. And so, as we saw the benefit of peer support and how it can help in someone's really acute time of need, we realized this was a great program for lots of different folks that may experience adverse events or medical errors or near misses at the bedside. In addition, we expanded what peer support can support around. And so historically, these things are around those issues of adverse events or medical errors. But we wanted, what we were seeing, particularly during the pandemic, and frankly, unfortunately, it has continued, was incivility at the bedside. And so we created a trauma-informed peer support program that supported around discrimination and bias at the bedside by patients and visitors. That was a big escalation. And that's a program we call P2P Safer, is to provide a safer program, a safer environment for our healthcare workforce. In that same distress bucket, we also launched coaching, particularly coaching around burnout, imposter phenomenon, et cetera, for our trainees, residents, and fellows. And that program for us really provided many of the skills that I wish I had had as a resident and fellow. The medicine in some ways was the easy part. It's how do you continue to develop your professional identity? How do you balance your work and life in a different way? So that coaching program was something that we're really, really proud of. At the tertiary level, that final level where distress has progressed to disease, we took a nudge from other groups that said, hey, you know what, EAP is not enough, and you need to look at your EAPs. And so we did. And what we said is, hey, what do we know about how many sessions it takes to improve anxiety and depression? And so we picked a new EAP, and we increased the number of visits our entire workforce would have by 33% for any incident that they would have, which to me in my specialty aligned better with how long it generally takes to feel better from mild to moderate depression. We looked at the diversity of the therapists that were available to our workforce. Obviously, when there is race concordance or ethnic concordance, that can be a big increase in the desire for people to utilize the services if they feel understood or they feel like their therapist gets them. And we felt like our prior vendor, we didn't feel like we had the diversity to offer our diverse workforce. And so we enhanced that.
That's exceptional. I was just gonna say, you truly offered the listeners what the definition is of multifaceted. Not only do you describe 3 different programs and approaches, but then within each program, customizing it to better meet the needs of the type of workforce and the diversity of our current workforce. So, thank you. Emma, I think you have another question for him, though.
Yeah, I mean, I was just gonna say, wow, like, I've heard you talk about all the work you've done and the policies and systems changes you've made, to really create this culture of well-being in this campaign at Northwestern, but every time I hear it, I remain impressed, and I have to assume that perhaps a listener who has clicked on this podcast has a vested interest or is about to embark or has already embarked on this journey as well. And perhaps after you listing all of those programs, they might see this as a little bit daunting. But we know that you're not the first institution to do something like this, but we really hope you're not the last, right? So I wonder if you can share a little bit about the journey, where you started, and maybe put people's minds at ease about the process, or at least let them know what they're in for, just so we see more uptick and more implementation and adaptation of things that exist.
Yeah, I think that's a really good point, and I want to be clear. All these things sound like you had a master plan when you started, but we were just putting one foot in front of the other. And the peer support program started off as a single program in a single department. We have a Scholars of Wellness program, and one of our scholars created a peer support program in the OBGYN department of one of our hospitals. That's where this started. And as we learned about the value that peer support can provide and how one would stand up a program in that one department turned into a hospital. And then as we figured out how you spread to a hospital, that one hospital turned into 11. And that was all for docs. And then all the docs, we understood what to do for the APPs. The APPs turned into the nurses turned into the pharmacists, and the pharmacists turned into the trainees. And so I don't believe in sort of trying to do it all at once, because generally when I've tried to do that, I do nothing. And so we just try to continue to grow and provide as many resources as we can. One program that I didn't mention earlier that was a big part of this, and if you have to start somewhere, we all have to sort of show utilization and impact. And the truth is, we can build all this stuff, but people may not utilize it because they don't feel safe to utilize it. Because historically, there has been A, stigma, and B, real repercussions for seeking out mental health care for healthcare workers that are worried about licensure issues. And so we used the Dr. Lorna Breen Foundation audit toolkit to help change the language on our credentialing forms to make sure that there would be no stigma for seeking out mental health care. And that was in conjunction with the state of Illinois also changing their verbiage on their licensure, because obviously you sort of have to do both. Otherwise, it's still important to do it locally, but when you have it both, that's when the research shows that our healthcare workers are more likely to utilize these sorts of resources. And we made those changes incredibly easy in some ways. I don't like to say any change is easy, but it was easy in the sense that we had the playbook on how to do it. And then we communicated it to folks to say, hey, we're doing things and we're serious about this. And I think that builds trust so that the other stuff also can be heard in the vein of, hey, you know what, now I can use that stuff. And so that's where I would say you should always start, just because it'll be difficult to sustain other things if people don't feel like they can use the resources that you provide them.
So I've had the privilege and pleasure of working with you for about, I don't know, 2.5, almost 3 years now, longer than that with the center, but 2.5, almost 3 years now on the APA Foundation Center for Workplace Mental Health Frontline Connect initiative. And, we recently released our toolkit, Improving Mental Health Care for Clinicians, Leading Interventions for Your Workforce, which you can find at frontlineconnect.org. But I wonder if you can share and speak to those folks who are like you, who are a leader at a hospital, health system, or healthcare institution, who are, a chief wellness officer, who are largely responsible for the mental health and well-being of their workforce. I wonder if you could speak to them and talk a little bit about what the toolkit we created together is, and how they can find value in it as they, again, embark or continue or, this journey to really just increase access to mental health care for those who need it.
Absolutely. And it's been my pleasure to work on Frontline Connect. And what I would say is, for me, in the role I sit, we've spent quite a bit of time, I would say over a decade, sort of saying what needs to happen and why does it need to happen. And action needs to be taken around wellness and mental health for our workforce. What I was looking for and what sort of drew me to the project was how and what. I'm a coach, and so how and what are the questions I care about. What are people actually able to do in the real world? What are they already doing that they've stood up that's making a difference? And that's what we tried to do with this virtual video toolkit. It was also I just didn't have time to read 300 pages. I just got to be honest with you. I wanted 15 minutes for someone to give me the seed of an idea of a program that they're using, because none of us, I think, can adopt a program just out of the box. We all have our own cultures, we all have our own resources, we all have our leadership. And so I don't need you to tell me every single detail, because it's not going to matter to me. It won't work that way for me. I just need some of the basic ideas of what are sort of these programs that could address X problem. And once I hear that, I can then take it through my lens and say, for us, we do have this need, or actually, we're doing okay on that thing. But if we have that need, how can I take the broad strokes of this program and apply it to my needs here at Northwestern? As you know, we identified the sort of exemplars across the country of people doing programs or having resources that were broadly available that we wanted people to know about, that we wanted to raise awareness about, that we get a chance to help our colleagues show off about their programs. And they were really gracious in sharing their programs, how they launched it, some of the key learnings from their launches. And as we continue to record more and more of these video case studies, I found that, hey, you know what? Like, why can't we do 4 or 5 of these? We're pretty close, and we know something about a little bit about a lot of these. And so, can we take that next step? And you've heard me talk about the influence of positive peer pressures. I can get competitive, and if I'm like, hey, this other healthcare system is doing this, why not us? That fuels me, and I believe it. Frankly, I use positive peer pressure on myself without knowing it, and it nudged us to do some of these sorts of programs all at once in the campaign that I mentioned.
I so agree with you. I love the toolkit. I was honored to be present with the official launching of the toolkit. And the fact that you can have digestible, inspirational knowledge transferred to you in a 5 to 10 minute video, if they're even that long in some cases, it's just wonderful. And it is the environment that we live in now. We are all fast paced. And so bite sized learning is wonderful. Another reason we're doing this podcast, bite sized learning. So, as we bring the podcast to a close, this is always the challenging question. So, get ready. This is your Jeopardy question. If you had to pick, what would be the 3 things that you want the listeners to really lock in on that you've said today, that you've shared today? Is it the toolkit that is a phenomenal resource to inspire you? Is it if you just start at one small unit at one hospital, you can grow from there?
I think for me, the first one is sometimes what I hear is people say, I think we're doing all right on mental health. Okay, that's too broad to me. What do you mean by that? Which level of prevention are we talking about? Are we talking about prevention at that primary level? Are we talking about you have good amount of resources at that distress level? Have you really checked to see if your folks in your workforce have good access to mental health care for mental health conditions? And how do you know? And so really assessing current state and the spectrum of needs as it relates to wellness and mental health conditions, I think is important, because what I think you might find is you are probably doing great in one of those buckets, maybe 2 of those buckets, but I don't know that many people that are doing great in every single bucket. And even us, there's still gaps for us. And so you have to know where you're at and where you really are sparse in your resources, because to me that's where you have the opportunity for the greatest impact. So that would be number one. Number two, I'm biased, but I do hope that people look at Frontline Connect. There's a lot of people's good work there, and I believe in acceleration, and uh, I don't really believe that my brain needs to be that smart. I should be learning from the best of other people, and I think it'll accelerate your journey about the options out there and the places where you may be able to make a difference. Even if after you do step one, you say, "Oh, I think I'm doing okay." Then if you see some of these initiatives, you're like, "Oh, you know what? I actually don't have any of those things." That may actually remind you to take a look at, the saying, you don't know what you don't know. You don't know what's out there, and so it'll be hard to judge what are some of the gaps without looking at some of these best practices. Number three, I would say this is the time. What I failed to mention earlier is we had looked at changing our credentialing language 5 years ago, and I couldn't get it done. I couldn't figure out how to do it. I couldn't really figure out who the players were. I don't know if it was top of mind for people. This is a different time. And so, for those of you that have maybe tried some of this stuff in the past and it's been shot down, or there's been blocks or barriers, timing is everything in change management. And so, this is the time to take a look, because what the disaster psychiatrists and psychologists will tell you is that it's not during the pandemic, it's not during a disaster that this stuff matters. It's the aftermath, where especially the folks that actually experienced and responded to disasters, in this case, the pandemic, actually feel it. And long after society has moved on, the folks that actually responded, whether it's military or in our case, the healthcare workforce, that's when these symptoms emerge. And so recovery is needed and potentially treatment is needed now. And so making sure that, we don't get sort of seduced or trapped in this idea of, oh, the pandemic's long over. This is what we know about pandemic recovery, or disaster recovery, I should say, is this is the time where those symptoms need to be, we need to be on the lookout for them and aggressively provide the resources to treat them because they are treatable.
The time is now. If there is a sliver of a silver lining of the pandemic, I think it is that it really has opened people's eyes. It's reduced some of the stigma. And it's also focused on the true need for these services across the board, but particularly for our healthcare workforce who are on the front lines every single day. So, Dr. Gaurava Agarwal and Emma Jellin, thank you so much for being here today. And then for additional resources from the AHA, go to aha.org/behavioral health. Thank you for your time and expertise and for the great work that you do each and every day. Gratitude.
Thanks for listening to Advancing Health. Please subscribe and rate us 5 stars on Apple Podcasts, Spotify, or wherever you get your podcasts.